In this video we will go through the intricate anatomy of the great vessels and nerves of the abdomen, a major entity mandatory to have a complete view on the abdomen and pelvis, especially when approaching these regions during surgery. We will start with an introduction to the great vessels and nerves of the abdomen, providing the general framework of this course. Following that, we will proceed, in turn, to the descriptive anatomy of the abdominal aorta, inferior vena cava, lymphatics of abdomen and pelvis, and lumbar autonomic system. The central vascular features of the posterior abdominal wall are the abdominal part of the aorta and the inferior vena cava, with the vein lying on the right side of the artery. They constitute the major structures of the retroperitoneal space. The portal venous drainage ensures the venous drainage of the gut. It is developed in the course of the anatomy of the liver and biliary tract. Each vessel will be studied following the same outline: origin, course, end and branches. Beginning with the abdominal aorta and its branches, the thoracic aorta becomes the abdominal aorta on passing behind the median arcuate ligament and between the crura of the diaphragm, on the front of the body of T12 vertebra. It passes downwards on the bodies of the lumbar vertebrae, inclining slightly to the left, with the left sympathetic trunk at its left margin. On the body of L4 it divides into the two common iliac arteries. Between the origins of the celiac trunk and the superior mesenteric artery, the aorta is crossed by the splenic vein and the body of the pancreas. Between the superior and inferior mesenteric origins lie the left renal vein, the uncinate process of the pancreas, and the third part of the duodenum. Below the duodenum, the aorta is covered by the parietal peritoneum of the floor of the left infracolic compartment. The surface marking of the abdominal aorta is from just above the transpyloric plane in the midline to a point just to the left of the midline level with the highest points of the iliac crests. The pulsation of the aorta can usually be felt, and in thin people who are lying down, often seen in the epigastrium or umbilical regions. The internal diameter of the aorta is about 2.5 centimeters. It decreases towards the origin of the renal arteries, where it does not exceed 1.5 centimeters. Below this point, it increases progressively in the adult. The abdominal aorta gives rise to two types of branches: parietal and visceral. The visceral arteries are either median and unique or lateral and paired. The end of the abdominal aorta will be developed later within the common iliac arteries. That being said, we will enumerate the branches of the abdominal aorta from top to bottom, beginning with parietal branches in order to mind map all these numerous arteries. The inferior phrenic arteries are paired and symmetrical. They leave the anterior wall of the aorta at the aortic opening, and each slopes upwards and forwards over the crus of the diaphragm, which they supply. They give off small suprarenal branches and anastomose with the esophageal and intercostal arteries. They may rise from the celiac trunk. The lumbar arteries, 4 in number, leave the abdominal aorta opposite the bodies of the upper 4 vertebrae. Hugging the bone, they pass beneath the lumbar sympathetic trunks and the fibrous arches in the psoas. On the right side, the inferior vena cava overlays the lumbar arteries. Each artery gives off posterior and spinal branches and passes laterally through the psoas muscle. The 3 upper arteries pass laterally behind quadratus lumborum muscle into the neurovascular plane between transversus abdominis and internal oblique. The 4th lumbar artery, like the subcostal, passes across to the neurovascular plane in front of the lower border of quadratus lumborum, along the upper margin of the iliolumbar ligament. There is no 5th lumbar artery. Its place is taken by the iliolumbar artery from the internal iliac. It ascends from the pelvis in front of the lumbosacral trunk and passes laterally behind the obturator nerve and psoas muscle. The lumbar branch supplies psoas and quadratus lumborum and gives a spinal branch which enters the L5-S1 intervertebral foramen. The iliac branch runs into the iliac fossa, supplying iliacus and the ilium, and ends in the anastomosis at the anterior superior iliac spine. This is the artery of the foregut, and its 3 branches: the left gastric, Splenic and common hepatic arteries supply not only the gut from the lower part of the esophagus down to the opening of the bile duct into the duodenum, but also the foregut derivatives, the liver and pancreas and the spleen. It arises from the front of the abdominal aorta as soon as that vessel has entered the abdomen, between the crura of the diaphragm and behind the median arcuate ligament, at the level of the body of T12 vertebra. It is usually a short wide trunk but may be longer, flanked by the celiac group of preaortic lymph nodes. The celiac ganglia lie one on each side and they send to the artery sympathetic nerves which are carried along all its branches. At the upper border of the pancreas the trunk divides into its 3 branches behind the peritoneum of the posterior wall of the lesser sac. The superior mesenteric artery arises from the front of the aorta a centimeter below the celiac trunk, at the level of L1 vertebra. It is directed steeply downwards behind the splenic vein and the neck of the pancreas. With the superior mesenteric vein on its right side it lies on the left renal vein, then on the uncinate process of the pancreas, then on the third part of the duodenum. Here the 2 vessels enter the upper end of the mesentery of the small intestine. They pass down to the right along the root of the mesentery and end at the ileum 60 cm proximal to the cecum. Pressure of the superior mesenteric artery on the left renal vein may produce left-sided varicocele in either sex, and pressure on the duodenum may give symptoms of chronic duodenal ileus. The suprarenal arteries arise from the aorta between its inferior phrenic and renal branches. They run laterally across the crus of the diaphragm. The right artery lies between the crus and the inferior vena cava and behind the bare area of the liver, and the left one is behind the posterior wall of the lesser sac, in the stomach bed. Each artery divides into several small branches before entering the gland. The renal arteries are large vessels arising at right angles from the aorta at the level of L2 vertebra. The left artery is shorter than the right. It crosses the left crus and sows, behind and somewhat above the left renal vein, both of which are covered by the tail of the pancreas and the splenic vessels. The longer right artery crosses the right crus and sows behind the inferior vena cava and the short right renal vein. These structures separate the artery from the head of the pancreas and bile duct and from the second part of the duodenum. Each artery approaches the hilum of the kidney to supply the renal segments. The early division of the right renal artery too close to the inferior vena cava constitutes a real challenge while approaching the right renal pedicle. Each renal artery gives off small suprarenal and ureteric branches. The gonadal arteries have a similar origin and course in both sexes. The testicular or ovarian arteries arise from near the front of the aorta, below the renal arteries but well above the origin of the inferior mesenteric. They slope steeply downwards over sows, the right artery first crossing the inferior vena cava, crossing the ureter and supplying its middle portion, and being themselves crossed by the colic vessels and the peritoneum of the floor of the infracolic compartment. They reach the pelvic brim about halfway between the sacroiliac joint and the inguinal ligament. At this point, their course is different in the 2 sexes. The testicular artery runs along the pelvic brim above the external iliac artery, enters the deep inguinal ring and passes in the spermatic cord to the testis. The ovarian artery crosses the pelvic brim and enters the suspensory ligament to pass to the ovary and uterine tube. The inferior mesenteric artery arises from the front of the aorta at the inferior border of the third part of the duodenum, opposite L3 vertebra, at the level of the umbilicus. It is much smaller than the superior mesenteric artery. It runs obliquely down to the pelvic brim immediately beneath the peritoneal floor of the left infracolic compartment. It crosses the pelvic brim at the bifurcation of the left common iliac vessels over the sacroiliac joint, at which point it converges on the ureter, at the apex of the A-shaped attachment of the sigmoid mesocolon. In its course it lies on the aorta, left psoas muscle and sympathetic trunk and the left common iliac artery, and hypogastric nerve. Over the pelvic brim it continues along the pelvic wall in the root of the sigmoid mesocolon as the superior rectal artery. The common iliac arteries are formed by the bifurcation of the aorta, on the body of L4 vertebra but to the left of the midline, so that the right artery is a centimeter longer than the left. Each passes to the front of the sacroiliac joint where the bifurcation into external and internal iliac arteries occurs. The ureter lies in front of this bifurcation or the very beginning of the external iliac. The left common iliac is crossed by the inferior mesenteric and superior rectal vessels. Each is also crossed by the sympathetic contributions to the superior hypogastric plexus and covered by the parietal peritoneum of the posterior abdominal wall. The common iliac artery bifurcates at the pelvic brim opposite the sacroiliac joint. From this point the internal iliac artery passes downwards and soon divides into a small posterior and a larger anterior division towards the greater sciatic notch. The posterior division breaks up into 3 branches, all of which are parietal and are named iliolumbar, lateral sacral and superior gluteal. The anterior division breaks up into as many as 9 branches, which can be remembered conveniently as 3 associated with the bladder, the superior vesicle, the obliterated umbilical and the inferior vesicle, 3 other visceral branches, the middle rectal, the uterine and the vaginal, and 3 parietal branches, the obturator, internal pudendal and inferior gluteal. These branches arise at variable levels and some may have common stems. Thus, they must be traced to their destinations before they can be properly named. Note that, in men, there are only 2 visceral arteries. The uterine is replaced by the artery of ductus deferens. The iliolumbar artery passes upwards out of the pelvis in front of the lumbosacral trunk and behind the obturator nerve, running laterally deep to the psoas muscle. Its lumbar branch is really the 5th lumbar segmental artery. It passes laterally to supply psoas and quadratus lumborum and, by its posterior branch, erector spinae. This vessel gives a spinal branch into the foramen between L5 vertebra and the sacrum. The iliac branch supplies the iliac fossa, the iliacus muscle and the iliac bone. It extends to the anastomosis around the anterior superior iliac spine with the deep and superficial circumflex iliac arteries, ascending branch of the lateral circumflex femoral artery and the upper branch of the deep division of the superior gluteal artery. The lateral sacral artery runs down lateral to the anterior sacral foramina in front of the roots of the sacral plexus. In the pelvis it supplies the roots and piriformis. Spinal branches enter the anterior sacral foramina, supply the spinal meninges and the roots of the spinal nerves and pass through the posterior sacral foramina to reach the muscles over the back of the sacrum. The artery takes over the segmental supply from the lumbar arteries and, as might be expected, it is often multiple. The commonest variant is for an upper sacral artery to supply the first 2 sacral segments and a lower sacral artery to supply the remaining segments in the pelvis. The superior gluteal artery, the largest of all the branches of the internal iliac, passes backwards by piercing the pelvic fascia usually between the lumbosacral trunk and S1 nerve, and leaves the pelvis through the greater sciatic foramen above the upper border of piriformis. The superior vesical artery is usually the highest anterior branch of the internal iliac and is the persistent patent proximal part of the fetal umbilical artery. The distal part becomes obliterated to form the medial umbilical ligament, which thus appears as the direct continuation of the vesical vessel. The superior vesical artery runs first along the side wall of the pelvis and then turns medially to reach the upper part of the bladder, often raising a fold of peritoneum from the pelvic wall. Apart from the bladder it supplies the adjacent ureter and ductus deferens. The inferior vesical artery, as might be expected, arises much lower than the superior and runs medially across the pelvic floor to supply the trigone and lower part of the bladder, the ureter, ductus deferens and seminal vesicle. It also usually gives rise to the prostatic artery. The middle rectal artery arises with or near the inferior vesicle, but may be absent, especially in the female where it may be said to be replaced by the uterine and vaginal branches. It runs towards the lower rectal wall, breaking into a leash of branches before entering it, and in the male it may give off the prostatic artery if that has not arisen from the inferior vesicle. The uterine artery crosses the pelvis in the base of the broad ligament, passing superficial to the ureter. At the cervix it turns upwards, closely applied to the muscle thereof, and runs alongside the uterus in the broad ligament. At the entrance of the uterine tube, it anastomoses end on with the tubal branch of the ovarian artery. The vaginal artery, often a branch of the uterine, supplies the very vascular walls of the upper part of the vagina. The obturator artery passes along the side wall of the pelvis below the nerve to enter the obturator foramen with the artery and vein and pass into the thigh. The artery gives off a small branch to the periosteum of the back of the pubis, and this vessel anastomoses with the pubic branch of the inferior epigastric artery. In about 50% of cases, this anastomotic connection opens up to become the accessory or abnormal obturator artery, replacing the normal branch from the internal iliac. In its passage from the inferior epigastric to the obturator foramen, it usually passes on the lateral side of the femoral ring, adjacent to the external iliac vein. When it lies at the medial side of the ring, alongside the edge of the lacunar ligament, it is vulnerable to injury or division if the ligament has to be incised to release a strangulated femoral hernia. The internal pudendal artery lies in front of the inferior gluteal, pierces the parietal pelvic fascia and passes out of the pelvis through the greater sciatic foramen below piriformis. It is distributed in the perineum to the anal region and the external genitalia. The inferior gluteal artery runs backwards through the parietal pelvic fascia, passes below S1 nerve root or sometimes S2, and leaves the pelvis through the greater sciatic foramen below piriformis, to continue its course in the buttock. The external iliac artery continues in the line of the common iliac, along the pelvic brim on psoas, and passes beneath the inguinal ligament to enter the femoral sheath as the femoral artery. Its two branches are given off just above the ligament. The inferior epigastric artery is a key feature at the deep inguinal ring and supplies the rectus muscle. The deep circumflex iliac artery runs above the inguinal ligament. The surface marking of the common and external iliac arteries is from the aortic bifurcation just to the left of the midline level, with the highest points of the iliac crests along a line slightly concave laterally to the midpoint between the anterior superior iliac spine and the pubic symphysis. The bifurcation of the common into the external and internal iliacs is 3 cm from the midline level, with the tubercles of the iliac crests. From the posterior surface at the bifurcation of the abdominal aorta, the small median sacral artery is given off, to run in the midline over the sacral promontory into the hollow of the sacrum. This is morphologically the direct continuation of the aorta, vestigial in talus man but large in creatures such as the crocodile. Now, let's move directly to the inferior vena cava and its tributaries. The inferior vena cava has a longer course than the aorta in the abdomen. It longer course than the aorta in the abdomen, lower than the bifurcation of the aorta, by the confluence of the two common iliac veins behind the right common iliac artery. It runs upwards on the right of the aorta beyond the aortic opening in the diaphragm, above which level it lies on the right crus behind the bare area of the liver, and extends to the central tendon of the diaphragm, which it pierces on a level with the body of T8 vertebra, 4 vertebrae higher than the beginning of the abdominal aorta. It lies on the bodies of the lumbar vertebrae, overlapping the right sympathetic trunk, and crosses the right renal artery. Above this level it is separated from the right crus by the contiguous edges of the right suprarenal gland and celiac ganglion, and the right inferior phrenic artery. At its commencement below, its tributaries lie posterior to the aorta, while, higher up, it and its tributaries lie on a more anterior plane, a result of its development. In the infracolic compartment, the inferior vena cava lies behind the peritoneum of the posterior abdominal wall. It is crossed by the root of the mesentery and above this by the third part of the duodenum. In the supracolic compartment it lies at first behind the portal vein, head of the pancreas and bile duct, then behind the peritoneum that forms the posterior wall of the epiploic foramen. Above this it is behind the bare area of the liver, into which it excavates a deep groove. The surface marking of the inferior vena cava is from a point on the intubacular plane 2.5 cm to the right of the midline to a point 2.5 cm to the right of the xiphosternal joint. Due to its complex embryological origin, the vena cava tributaries are not identical with the branches of the abdominal aorta. In particular, there is none corresponding to the 3 ventral branches to the gut. The blood from the alimentary tract, pancreas and spleen is collected by the portal venous system, and only after passing through the liver does it reach the vena cava via the hepatic veins, the vena cava's highest tributaries. Above its formation by the union of the 2 common iliac veins, the other tributaries, in ascending order, are the 4th and 3rd lumbar veins of both sides, right gonadal vein, both renal veins, right lumbar azygos vein, right suprarenal vein and both inferior phrenics. The lumbar veins accompany the lumbar arteries and drain the lateral and posterior abdominal walls, with anastomotic connections anteriorly with the epigastric veins and posteriorly with the vertebral venous plexuses. The 4th and 3rd empty into the vena cava, those from the left pass behind the aorta, and all are expected to lie behind the sympathetic trunks, but occasionally one or more may be in front. The 2nd and 1st do not usually reach the vena cava but join the ascending lumbar vein, which unites common iliac and iliolumbar veins and passes vertically upwards behind psoas and in front of the lumbar transverse processes. That on the right passes through the same opening as the right sympathetic trunk, and that on the left perforates the left crus. Each joins the subcostal vein to form the azygos vein to the right and hemiazygos vein to the left. The lumbar azygos vein may also run into this junction and have connections with the 1st and or 2nd lumbars. The right lumbar azygos vein is a very small vessel, frequently obliterated, connecting the posterior surface of the vena cava at renal vein level with the azygos vein. It lies behind psoas, medial to the ascending lumbar vein. If present, the left lumbar azygos vein connects the back of the left renal vein to the hemiazygos vein. The renal veins lie in front of the renal arteries and behind the pancreas, and join the vena cava at right angles, at the level of L2 vertebra. Their internal diameter varies from 8 to 10 mm. Each emerges from the hilum of the kidney as 5 or 6 tributaries which soon unite. In length and in territory drained, the 2 veins are very different. The left renal vein is 3 times as long as the right, 7.5 cm compared with 2.5 cm, having to cross in front of the aorta. It receives the left suprarenal vein and left gonadal vein, possibly the left inferior phrenic vein, and is connected with the left ascending lumbar and lumbar azygos veins and hence with the azygos and vertebral systems. In contrast, the shorter right renal vein drains only its own kidney unless the right testicular vein also enters it. The gonadal veins accompany the arteries, testicular or ovarian, and each is usually paired. As they run up on psoas, the 2 venae comitantes unite. On the right, the vein is usually said to enter the vena cava just below the renal vein, but the right testicular vein may join the renal vein. On the left, it invariably joins the left renal vein. The 3 main hepatic veins, right, central and left, and several accessory hepatic veins enter the vena cava as it lies in its groove on the back of the liver. The hepatic veins have no extrahepatic course, being completely engulfed in liver substance and hence easily forgotten when trying to recall the vena cava tributaries. The inferior phrenic veins accompany the arteries on the lower surface of the diaphragm and normally join the vena cava just above the hepatic veins, but the left vessel may join the left renal or suprarenal vein, or even be double with different destinations. Each common iliac vein is formed in front of the sacroiliac joint by the union of the internal iliac vein from the pelvis and the external iliac vein, the continuation of the femoral vein, which enters the abdomen on the medial side of its corresponding artery and runs along the pelvic brim behind the artery. The 2 common iliac veins continue upwards behind their arteries to unite to form the vena cava behind the right common iliac artery. Because the vena cava is to the right of the midline, the left common iliac vein is longer than the right. It joins its fellow almost at a right angle after bulging forwards across the body of L5 vertebra and is often compressed by the overlying artery. Each common iliac vein receives iliolumbar and perhaps lateral sacral veins, while the left usually receives the median sacral vein which lies on the right of the corresponding artery. The internal iliac vein, a wide vessel about 3 cm long, begins above the greater sciatic notch by the confluence of gluteal veins with others that accompany branches of the internal iliac arteries. It passes upwards and forwards out of the pelvis, above and behind its artery, onto the medial surface of psoas major, where it joins the external iliac vein to form the common iliac. Apart from tributaries that correspond to arteries, the vein receives the uterine or vesicoprostatic venous plexuses, and the rectal venous plexuses which also communicate with the portal system by the inferior mesenteric vein. By the lateral sacral veins it communicates with the vertebral venous plexuses. There are no valves in pelvic veins. Sudden increase in pelvic pressure as in coughing may be momentarily more than the inferior vena cava can accommodate, and this drives blood backwards up the internal vertebral plexus, into posterior intercostal veins and by azygos veins into the superior vena cava, bypassing the diaphragm. It is conceivable that emboli from disease of the pelvic viscera can find their way by occasional reflex blood flow into the vertebrae. In this way secondary carcinomatous deposits may appear in the vertebrae from primary growths in any of the pelvic viscera. After the arteries, the veins, let's now take a look at how the lymph drainage of the abdomen is organized and connected to blood circulation. From nodes which drain the alimentary tract, liver, gallbladder and biliary tract, spleen and pancreas, lymphatics pass back along the celiac, superior and inferior mesenteric arteries to preaortic nodes situated around the origins of these 3 vessels. Similarly, lymphatics pass back along the paired branches of the aorta, both visceral and parietal, to para-aortic nodes which lie alongside the aorta at the origins of the paired vessels. The lymph drainage of any viscus follows its artery back to the aorta. Lymph from pelvic viscera drains through nodes along the internal iliac vessels. The lower limb drains by deep inguinal nodes through the femoral canal into nodes along the external iliac vessels. Both these iliac groups drain up to the para-aortic nodes. The various aortic nodes lie in masses that cannot be readily demonstrated separately by dissection, but clinically their described groups are accurately demarcated from one another. From the highest of these aortic groups, a variable number of intestinal and lumbar lymph trunks and smaller lymphatics from the posterior ends of the lower intercostal spaces join to form the elongated, sac-like cisterna chyli, though frequently the single cisterna is replaced by a confluence or ret of trunks. It is situated under cover of the right crus, in front of the bodies of L1 and L2 vertebrae, between the aorta and azygos vein. Its upper end becomes continuous with the thoracic duct. Some of the fat absorbed by intestinal cells enters blood capillaries and so reaches the liver directly by the portal vein, but other processed lipid molecules enter the lacteals of the intestinal villi as chylomicrons, so producing the milky-looking lymph which enters the bloodstream via the cisterna chyli and thoracic duct. In the same spirit of having a complete view of the topographic and functional anatomy of the abdomen, it is mandatory to understand the autonomic systematization of the abdominal viscera, sympathetic and parasympathetic, and hence discover the structures behind this function. The lumbar part of the sympathetic trunk brings preganglionic fibers descending from the lower thoracic trunk, and it receives a further input of preganglionic fibers from the first and second lumbar nerves. Its ganglia give off the regular somatic and visceral branches, and the trunk passes down across the pelvic brim to become the sacral part of the trunk. The lumbar part of the sympathetic trunk enters the abdomen by passing behind the medial arcuate ligament on the front of psoas major. Passing in front of the psoas fascia, the trunk lies on the vertebral bodies just touching the medial margin of the psoas muscle. As elsewhere, it lies in front of the segmental vessels. The lumbar arteries and veins are expected to pass behind the trunk to reach the fibrous arches in the origin of the psoas muscle, but some lumbar veins may pass in front of the trunk, a point to be watched in lumbar sympathectomy. The common iliac vessels lie in front of the trunks at the pelvic brim. They are not segmental vessels in series with the lumbar vessels, but, in the quadrupedal position, are merely branches of the aorta and vena cava passing ventrally to the pelvis and hind limb, so the sympathetic trunks naturally pass dorsal to them. The left lumbar trunk lies along the left margin of the aorta with para-aortic lymph nodes in front of it, while the right trunk lies behind the inferior vena cava, a result of the asymmetry of the two vessels. The trunks themselves are symmetrically placed in their whole extent. The lumbar ganglia are conventionally 4 in number, but fusion of ganglia may reduce them. White rami communicantes are received from the first 2 lumbar nerves, and small accessory ganglia lie at this level within the substance of psoas. Here relay occurs and the grey rami return to the first lumbar nerves within the substance of the muscle, especially the first. The other white rami for the sympathetic trunk itself pass from the upper 2 lumbar nerves behind the fibrous arches in psoas. They join the trunk and run down to relay in the lumbar and sacral ganglia, for the somatic and visceral branches therefrom. Somatic branches, grey rami communicantes, pass from the lumbar ganglia to all 5 lumbar nerves, for distribution to the body wall and lower limb. They accompany the lumbar vessels behind the fibrous arches in psoas. Those for L1 and L2 are very sparse, since almost all the relay at these levels takes place in the accessory ganglia in psoas. Visceral branches, lumbar splanchnic nerves, arise from all lumbar ganglia to join the celiac, aortic and superior hypogastric plexuses. Those from the 3rd and 4th ganglia pass respectively in front of and behind the common iliac arteries, so forming loops under those vessels. They join with each other and with fibers from the aortic plexus in front of L5 vertebra to form the superior hypogastric plexus. This was previously known as the presacral nerve but was a misnomer. It is prelumbar, not presacral, and is not a single nerve but a plexus. The plexus breaks up into the right and left hypogastric nerves, which again may not be single but a bundle, which run down into the pelvis to join the inferior hypogastric plexus. There are a few ganglion cells in the superior hypogastric plexus. The preganglionic white fibers in the hypogastric nerves pass through to relay in ganglia in the inferior hypogastric plexuses, which supply pelvic viscera. They give no branches to the abdominal viscera, which are supplied by the celiac plexus. The celiac plexus lies around the origin of the celiac trunk above the upper border of the pancreas. The greater and lesser splanchnic nerves pierce the crura of the diaphragm and enter the celiac ganglia. These are 2 semilunar masses, right and left, which overlap the edges of the aorta and encroach laterally on the crura of the diaphragm. Either or both ganglia may be separated into 2 or more ganglionic masses. The splanchnic nerves are almost all preganglionic white and they relay in the celiac ganglia. The least splanchnic nerve relays in a small renal ganglion behind the renal artery. This is merely an offshoot of the main celiac ganglion itself. Separated masses of ganglion may lie on the aorta at the superior and even the inferior mesenteric artery origins. Such irregularity, of separation or of fusion, is common in autonomic ganglia. From the celiac ganglia, the mass of postganglionic fibers build up a rich network on the aorta, the celiac plexus. The fibers supply all the abdominal viscera, which they reach by streaming along the visceral branches of the aorta. Thus, the midline gut arteries, celiac, and superior and inferior mesenteric carry sympathetic fibers to the foregut and its derivatives, to the midgut, and to the hindgut down to the lower rectum. Similarly, the paired visceral arteries carry fibers from the celiac plexus. Those passing to the kidney pick up the branches of the renal ganglion to form the renal plexus behind the renal artery. Testis and ovary are likewise supplied by a sympathetic plexus that accompanies each gonadal artery. Some postganglionic fibers are not used up at the inferior mesenteric artery, in which case they stream down over the aorta to enter the superior hypogastric plexus. The sympathetic fibers are vasomotor, motor to sphincters, the ileocolic for instance, inhibitory to peristalsis, and carry sensory fibers to all the viscera supplied. The suprarenal gland has a second supply. Preganglionic fibers from the lesser or greater splanchnic nerve pass without relay to the cells of the suprarenal medulla. These cells share a common origin from neural crest ectoderm with the cell bodies of sympathetic ganglia. These preganglionic fibers cause the suprarenal medulla to pour forth adrenaline. The vasomotor supply to the suprarenal gland reaches it by postganglionic fibers from regular relay in the celiac ganglion. Now, after following each link of the sympathetic supply of the abdomen, let's consider how the parasympathetic manages to plug into the visceral plexuses. Both vagi, intermixed in the vagal trunks, contribute fibers to the celiac plexus. Without relay they accompany the postganglionic sympathetic fibers of the plexus, but not to the whole territory. To the gut they pass along the foregut and midgut arteries only as far as the transverse colon, no mean feat. However, for a cranial nerve, they enter the renal plexus and pass into the kidney, for a purpose which is obscure. They do not supply the gonads or suprarenals, as far as is known. The vagus is motor and secretomotor to the gut and its glands down to the transverse colon. The abdominal level of the sympathetic trunk been seen, let's get to have a look at the pelvic portion. The trunks cross the pelvic brim behind the common iliac vessels and lie in the concavity of the sacrum medial to the anterior sacral foramina. Each has characteristically 4 ganglia. The trunks lie parallel with the lateral margin of the sacrum and converge at the front of the coccyx to unite at a small swelling, the ganglion impa. Somatic branches are given off to all the sacral nerves for the lower limb and perineum and smaller vascular filaments to the lateral and median sacral vessels. Visceral branches leave the ganglia to mingle with the inferior hypogastric plexus. There are 2 inferior hypogastric plexuses, right and left, collectively forming the pelvic plexus. They must not be confused with the single midline superior hypogastric plexus. The inferior hypogastric plexus is an autonomic plexus on the side wall of the pelvis, lateral to the rectum and within the parietal pelvic fascia. Its sympathetic components are derived from the superior hypogastric plexus by the hypogastric nerve and by branches from the sacral ganglia of the sympathetic trunk. Its parasympathetic components are carried by branches from S2, 3 and 4 nerves. These are the pelvic splanchnic nerves. The plexus is a coarse, flat meshwork, enlarged in places in ganglia. It measures nearly 5 cm in anteroposterior and about 2 cm in vertical dimension. About half the fibers in the hypogastric nerves are myelinated preganglionic and they relay in the ganglia of the inferior hypogastric plexus. The remaining sympathetic fibers and all the parasympathetic fibers pass through without relay. The parasympathetic motor and secretomotor fibers relay in the walls of the viscera. The branches of the hypogastric plexuses are wholly visceral and run in leashes of nerves bound up in condensed bundles of fibrous tissue. In their passage through the fibrous tissue above the pelvic floor they are accompanied by visceral branches of the internal iliac artery and vein. These neurovascular bundles in their fibrous tissue condensations produce certain of the named ligaments of the pelvic viscera, the lateral ligaments of the bladder, of the cervix and of the rectum for instance. While it is well established that sympathetic vasoconstrictor fibers accompany all arteries to the pelvic viscera, much ignorance still exists as to the exact course of certain of the motor and sensory fibers to these organs. In general it appears that the muscles of the bladder, detrusor muscle, and rectum are innervated by the pelvic splanchnics, the smooth muscle of the internal sphincter of the bladder through the superior hypogastric plexus and the smooth muscle of the internal sphincter of the anal canal by branches from the sacral ganglia which pass through the pelvic plexuses. The course of the afferent fibers is less well understood. Normal sensations of distension of bladder and rectum probably pass through the pelvic splanchnic nerves. Pain fibers probably take the same course, though some pass in the hypogastric nerves as well. Pain fibers from the body of the uterus and the upper part of the cervix appear to run with the hypogastric nerves, the cell bodies being in the dorsal root ganglia of T10, L1 nerves, but pain fibers from the lower cervix travel with the parasympathetic nerves. As well as being motor to the smooth muscle of the pelvic viscera, the pelvic splanchnic nerves supply the colon from the splenic flexure distally. Many of these branches run up from the inferior hypogastric plexus to the superior hypogastric plexus and leave it by a separate trunk which joins the inferior mesenteric artery, by which they are distributed to the descending and sigmoid colon. Others make their own way up behind the peritoneum without becoming involved in the superior plexus. Thus, in the pelvis the two parts of the autonomic system conform to their motor functions higher up. The pelvic parasympathetics are motor to the emptying muscle of the bladder, and of the gut from splenic flexure to rectum. They are secretomotor to the gut. The sympathetics are motor to the visceral muscle sphincters of the bladder and anal canal. They are motor, too, to the ductus deferens, seminal vesicles and prostatic muscle. The sympathetic probably also supplies motor fibers to the uterine muscle. The sensory supply to abdominal viscera and gonads is sympathetic, and this includes the descending colon. But there is a change of sensory supply to the derivatives of the cloaca. Bladder, rectal ampulla and anal canal receive sensory fibers from the pelvic parasympathetics. So, too, do the lower cervix and upper vagina, but the body of the uterus receives its sensory supply from the sympathetic. Thus, pain from the prostate or rectum, mediated by the pelvic splanchnics to S2 to S4 segments, may be referred to these dermatums, posterior ephemeral cutaneous nerve, and so be mistaken for sciatica. Lumbar sympathectomy for removal of the third and fourth lumbar ganglia. The approach is through a transverse muscle cutting incision in the anterior abdominal wall on the appropriate side. The intact peritoneum is stripped off right round to the vertebral column, carefully avoiding damage to the gonadal vessels, ureter and genitofemoral nerve overlying psoas major. The right sympathetic trunk is under cover of the inferior vena cava, which must be gently displaced without tearing lumbar vessels. Some lumbar vessels may pass in front of the trunks. On the left, the trunk is parallel with the margin of the aorta. The third and fourth ganglia and the intervening part of the trunk are removed. The study of the great vessels of the abdomen and pelvis is mandatory for a complete view of the anatomy of this part of the body, particularly during surgery. The anatomy of the autonomic nerve supply of the abdomen is the first step for the understanding of its systematization.